Sorry about that. Okay. Hi, everyone. We are the NYC Healthcare Group, and our project is based on an analysis of health and healthcare needs for New York City with a focus and emphasis on Queens. New York City is a vastly diverse city and a melting pot of individuals from several different communities from a wide array of ethnic and racial groups. However, with its dense population comes inadequate allocation of resources. For our purposes, we will be focusing specifically on healthcare and how so many facilities were compelled to operate beyond maximum capacity and several different stages of the COVID-19 pandemic, especially its peaks. We aim to analyze the impacts of new healthcare implementations on minority groups while considering other factors of everyday living, like transportation, income, government provided healthcare, and more. We aim to build an analysis of the general and COVID-specific health conditions in order to best conclude appropriate policy and healthcare recommendations.
Focusing on Queens, it is the second most populated county in New York City after Brooklyn. Due to the COVID-19 pandemic, New York experienced a decline of 1.6% in population, which is the highest among the entirety of the United States, with Queens alone experiencing a decline of 0.92% in the past year. The financial situation of New York City has relatively stayed stagnant since the beginning of the pandemic, slowly rebounding from the economic devastation of high unemployment rates, with the city's current unemployment rate being 10.5%. This statistic is twice the national average of 5.4%. I'm going to hand it over to Sanvi.
The Queen's number of cases has been greater than the citywide average for the past month, stressing the disproportionate impact this virus has had on this region. During the past week, new hospital admissions have received an 8.8 decrease from the prior 7-day average, but New York has shown clear disparities between vaccination rates of white people versus people of color. 67.5% of people with at least one vaccine dose is white, while the rest of the vaccinated population is divided among African Americans, Asians, and Hispanic Americans. A mere 21.8% of Hispanic or Latino people compose those who are vaccinated, while 78.2% are non-Hispanic.
We would like to formally thank the resources provided to us by the International Socioeconomics Laboratory, which have gone a long way in helping support our research conducted during the spring semester of 2022. We would also like to thank the support of our principal investigators for being able to conduct this study and our research fellow, Paul Joseph. So now on to materials and methods. In order to perform an effective case study analysis of Queens with respect to New York City as well, the study utilized archive data and past survey collection in order to investigate how different minority groups have been impacted in terms of access to healthcare during the COVID-19 pandemic. Through the collection of archive data, we analyzed socioeconomic and COVID-19 related conditions and their impact on urban areas such as the various neighborhoods of Queens.
So we analyzed 4 different variables: race, poverty, age, and borough of residence to measure how minority groups have been impacted by the COVID-19 pandemic. So firstly, for race, analysis of the data depicted in the graphs demonstrates that Hispanic and Latino residents of New York City have the highest number of confirmed cases at 238,564 cases confirmed, with the highest death rate at 745.5 and the highest hospitalization rate at 1,535. Black and African American residents have the second highest death rate at 680.2 and the second highest hospitalization rate at 1,472. Despite having the second highest confirmed case count at 198,714, white residents have the second lowest hospitalization and death rates at 783 and 1,472.6 respectively. This demonstrates that Hispanic and Latino and Black and African American citizens have been the most impacted by the COVID-19 pandemic. It also shows that white residents of New York City were less likely to die and be hospitalized by COVID-19 than their Hispanic and Black counterparts, pointing at the racial disparities of the healthcare system.
Moving on to poverty levels, the data concludes that there is a direct correlation between poverty levels and positive COVID-19 cases, with populations with low poverty levels reporting 27.6% of the population testing positive for COVID-19, and areas of very high levels of poverty reporting a positive test rate of 39.9%. This trend can likely be attributed to high poverty populations being less able to work from home during the pandemic compared to low poverty populations.
The next variable that we analyzed was age levels, and the analysis of different age groups that were affected further affirms the disproportionate allocation of resources within New York City, because individuals aged 25 to 35 were at a slightly lower risk of contracting COVID at 28.7%, and other age groups were at a higher risk. And the slight variance in data can possibly be attributed to individuals aged 13 to 17 being at a higher exposure risk for COVID-19 due to factors such as attending school. And the last variable that we analyzed was borough residents and communities. And while New York City had a positive case rate of 37.9%, the Queens neighborhood with the highest positive case rate, which was Corona and North Corona, had a positive case percent of 55.4%, which is over half of the population. And the Queens neighborhood with the lowest rate, Jackson Heights and Rikers Island, had a percent of 42.7%, which is still a vastly higher number than New York's average. And this stark difference in COVID cases in comparison to New York's and Queens can be attributed to the lack of healthcare facilities in Queens, specifically within the neighborhood of Corona and North Corona.
Lastly, as for policy implications, throughout the analysis of the COVID-19 rates among minorities in the different boroughs, the sharp disproportionate nature of the resources provided by healthcare is evident. It is essential to note that receiving proper healthcare should be viewed as a right instead of a privilege, and further funding and policy initiatives regarding mitigating the gap and disparities need to be addressed as soon as possible. Other programs, for example, other programs such as Medicare and Medicaid need to be established and implemented in real time to see actual results and to provide proper healthcare access to everyone. Thank you for listening.
May I take any questions from the judges or any kind of feedback?
I think I might have one. So thank you for your presentation. I thought it was really interesting and really well thought. It was sometimes like a bit hard to follow because of the amount of figures and the rhythm of it, but at the same time, you don't have a lot of time to present, so you have to go that fast. I believe that's also what we pushed you to go that fast. I understand that you have an hypothesis when it comes to class disparity and the reasons why neighborhoods that are lower income are more affected. But I didn't hear any hypothesis concerning disparities when it comes to race. So maybe I missed it, or maybe you don't have an hypothesis yet, or maybe you didn't mention it. So that's my question. Do you have an hypothesis that explains potentially why there is a disparity in the way in which COVID affected different racial groups?
Does anyone want to? Oh, Sanve, if you want to take the question.
Okay, thank you so much. So I would say that we did not explicitly state a hypothesis just because you know, some of our data was a little bit difficult to draw conclusions like that. But we definitely considered that kind of thing when we were building our project and discussing like what we wanted to do. In terms of race, I mean, there are two things, right? There's the health area of it, in that statistically minority groups are more likely to contract COVID-19 than white Americans, and that has been put out by the CDC. And then there's also the disparities in healthcare that come with racial discrimination and with, say, where you live, maybe a lower income neighborhood, which correlates to a higher minority rate, which also correlates to less public facility and less public service. And you are just not given the same amount of health services that a neighborhood that would be, you know, a higher income, maybe more white residents, something like that. So that is along the lines of our hypothesis and our thinking when it came to drawing conclusions about a correlation between race and healthcare.
And just to kind of add on to that, I think we were also kind of keeping in mind of like historically neighborhoods that were disadvantaged in New York City to begin with. So starting from like the early 20th century, or like the mid 20th century, and like its continuations to present day. So kind of taking all of that into account, we kind of wanted to draw connections to the trends that kind of correlate with the disparities that existed before, and like how minorities are being affected right now in New York City.
Thank you.
That was really good, guys, and the findings are sobering. I think that in response to the question about a race hypothesis, you guys do have a thread that you could pursue in more detail if you choose to. You mentioned that the high COVID contraction rates are more prevalent among people who are unable to work from home. So if you have data that shows the percentage of racial minorities who are working in service occupations like fast food, healthcare, and in particular healthcare that involves intimate contact with patients, like removing bedpans and things like that, and I think you'd be able to build an even stronger case for the racial disparities that you show here.
Thank you so much. Yeah,
you're welcome. I do have a question. You guys mentioned two variables early on in your presentation: population loss in New York City as a result of the onset of COVID, and also high unemployment. But I didn't hear much about those two variables as the presentation continued. Could you say more about what you see as the impact of those two variables on your outcome on COVID contractions?
Does anyone? Yeah, Sophia, if you want to take it.
Yeah, definitely. So our research was primarily focusing on healthcare, but obviously unemployment and population decline are both like very related to healthcare. So although we didn't look at it that much later on in our research, we did see that like specifically we did measure poverty levels, which can be linked to unemployment. And then we saw that COVID did cause an increase in poverty, and that communities that were in higher poverty had higher rates of contracting COVID. So that's kind of how we tried to relate it, but I think there's definitely a lot more research that could be done in that area.
Great, thank you.